Welcome to Bladder Preservation, Understanding Alternates to Radical Cystectomy, a patient insight webinar from the Bladder Cancer Advocacy Network. We'd like to thank our sponsors for tonight's program, Bristol Myers Squibb, EMD Serono Pfizer Partnership, Genentech, PhotoCure, and Merck for their support of the Patient Insight webinar series. My name is Stephanie Chisholm, and I'm the Director of Education and Research at Beacon. I'm joined today by Columbia University urologist Dr. James McKiernan and The Ohio State University urologist Dr. Cheryl Lee to discuss alternatives to radical cystectomy. Welcome. It's a pleasure to have you both with us.
Thank you.
It's wonderful to be here.
Great. Let me first introduce our presenters. Dr. Jim McKiernan is the John K. Latimer Professor and Chair of the Department of Urology of the College of Physicians and Surgeons and Urologist-in-Chief at New York Presbyterian Columbia Presbyterian Hospital. Dr. McKiernan graduated from Johns Hopkins University with a BA in biology and received his medical degree from Columbia University College of Physicians and Surgeons. He specializes in urologic oncology, particularly surgical therapy in high-risk patients with bladder and kidney cancer. Dr. Cheryl Lee is the chair of the Department of Urology and Dorothy M. Davis Chair in Cancer Research at the Wexner Medical Center at The Ohio State University. He's dedicated to improving the care of bladder cancer patients through advocacy, education, and research. Dr. Lee has been involved in more than 50 clinical research trials. Recent research has focused on strategies to improve outcomes and quality of life for patients who suffered impairments following bladder removal surgery. Dr. Lee is a member of the Board of Directors of the Bladder Cancer Advocacy Network and of the Regional Division of the American Cancer Society. Through her role as member of Education Council on the AUA, she's active in the education of urologists and urologic trainees. So welcome to both of you. We're delighted to have you here for our program.
Great to be here. Thank you.
Absolutely.
Dr. Lee, I'm going to try to turn this mouse over to you, so you should be able to advance the slides. If you can't, just let me know and I'll advance them for you.
That sounds fantastic. Well, again, I want to welcome everybody in the survivor community to our webinar this evening. This type of program, I believe, is really important for patients, for their families, for caregivers, because it allows us to really have a very personal conversation about important issues. Now, this particular webinar tonight is going to touch on a number of issues in thinking about how patients should approach bladder preservation. It's important to know about the common systemic therapies or chemotherapies or immune therapies that are available to patients who have deeply invasive bladder cancer. In addition, we'll be thinking about what is the patient response to those kinds of treatments. Additionally, we'll be talking about who is a good candidate to avoid radical surgery or radical bladder removal or cystectomy. And we'll think about some of the potential risks that are involved in delaying or omitting cystectomy. And although this won't be the central topic in this webinar, we will touch on the role of radiation therapy in the patient who does not have radical surgery. And we can go to the next slide. Well, you know what, let me try one. Let's go ahead to the next slide. So first, I think it's worthwhile for us to take a step back and think about bladder cancer as a disease. And Stephanie, can you see my mouse at this time?
I can see the mouse, but
okay.
If you want to try to
in the cartoon image on the right lower part of the screen, what we see is an image of a bladder. And if you look at the small box, it's really encircling the wall of the bladder. And if you took a section of the wall of the bladder and magnified it, you'd see that the bladder is comprised of a series of layers. Now, Stephanie, if you can you try to give me the screen back, and I want to be able to highlight that.
Mm-hmm.
Well, and that's unfortunately, I don't think that's going to work.
You should be able to. There you go. You're moving it. You have it.
And can you see me right now moving around the box?
Yes,
Great.
we can see you.
So the bladder is comprised of a series of layers, as we see here in the diagram. The inner part of the layer, inner part of the bladder is noted in this area, and we see that there are layers deep to the surface. As cancer cells grow into the wall or invade the wall, there's a higher chance of cells spreading from the bladder and going to other organs. That might be lymph nodes or lung, bone, or liver. So we take it very seriously when we see cancer cells in this layer of deep, thick muscle, and that's called muscle-invasive bladder cancer. And that's primarily the group of patients we're going to be talking about today. The deeper cells grow into that bladder wall, the higher the stage of the cancer, or the higher the extent of the cancer. And if we think about what are the standard treatments for patients with cancers invading the deep muscle wall of the bladder, that would be systemic chemotherapy. That means chemotherapy that's not instilled in the bladder, but into the veins and being delivered to the entire body. Then, ideally, we would move to bladder removal. Another standard treatment option is going straight to removing the bladder and skipping the chemotherapy. And that might be important because patients may not agree to chemotherapy. They may not be eligible for chemotherapy, for example, if their kidney function isn't working normally. But for those, for example, who are interested in preserving their bladder, a standard treatment option could be radiation treatment. And in fact, we use radiation in combination with some surgery and with some of that chemotherapy, and we call it trimodality therapy. That's when we go in, not doing a big open surgery, but going in to scrape the tumor away as deeply as possible. That's the transurethral resection of bladder tumor, or TURBT. And then we move to a treatment process of chemotherapy and radiation at the same time. The chemotherapy actually helps to improve the efficacy of the radiation. So that is what we would term trimodality therapy, and that's historically been the primary way of preserving the bladder. Next slide. One question that came up when we, can we go back one? One question that came up for this webinar was, does any of this webinar pertain to non-invasive bladder cancer? Like I mentioned before, the majority of our conversation is going to be focused on people with more advanced bladder cancer invading into the deep wall or the deep muscle of the bladder. So most of what we will discuss tonight will not pertain to non-invasive bladder cancer. Next slide.
So Cheryl, go ahead and just hit advance. You should be able to move it to the next slide.
Okay.
If you just hit enter, you should go right to the next slide. There you go.
So let's talk for a minute about radical cystectomy as an important treatment for bladder cancer. This is a radical surgery that involves removal of the bladder and generally the prostate in men. In women, it involves removal of the bladder, the urethra, and sometimes the female organs. And as we remove the bladder, we need to revise the urinary system, and that might mean that the patient has to have either an ileal conduit, as seen on the image on the left, some type of colon or internalized diversion that still has a small stoma on the outside that needs to be catheterized, or an internalized neobladder or new bladder. There, unfortunately, are real implications of having to have radical surgery and or a urinary diversion. And then Stephanie, I'm sorry, but I am not, there we go. As part of the considerations for having radical surgery, we have to think of complication risk, tolerance for surgery, and many other things. On the flip side, for the person who doesn't want to have radical surgery, we have to recognize that leaving the bladder in place with a serious bladder cancer there, even after it's been treated, could result in a local recurrence. In other words, the cancer could come back in the bladder. It's also possible that the cancer could come back in the bladder and then could move to other organs. And importantly, when cancers return, they can result in local symptoms for patients that could involve bleeding, pain, or trouble urinating. And of course, if patients decide to preserve their bladder and undergo other treatments, we still need to make sure over time we are surveying that bladder to make sure no cancer has returned. And I may have to have you advance, Stephanie, because it is unfortunately not advancing. There you go. Thank you. So why avoid surgery anyway? Surgery is very effective in controlling bladder cancer. Why would anyone want to avoid surgery? Well, bladder removal is a major operation. It has, unfortunately, a high complication rate. And that can be upwards of 50 to 60%, and in some studies even higher than that. Now, most of these complications are going to be kind of a low to mid risk of a complication, but some can be quite serious and life-threatening. The other reality of it is that any major surgery is associated with a period of recovery. And particularly as individuals age, that recovery could threaten the independence of someone. So these are important considerations. And I think importantly, even for those patients who have a low risk of complication or for those who recover well after surgery, there are real quality of life changes that impact patient urinary function because of the urinary diversion. Some can have some changes to their bowel function, and then certainly there can be implications for decline in sexual function. Next slide. So as we think of who might be a good candidate to seek alternative therapies for radical cystectomy, we can look at a number of reasons why someone would want to seek out another treatment. One, surgery might be risky for some patients, and this could be for a number of reasons. They might have had prior radiation. They might have had multiple surgeries in the past. They might have an existing ostomy. They may have had other vascular procedures where they have vascular grafts that could be disturbed through pelvic surgery. They might just have very extreme medical conditions or comorbidities. And certainly as people age, they are at higher risk for complications and will be and may be considered a poor surgical candidate. Additionally, extreme obesity can make surgery very difficult, and that may be another reason why one would want to avoid radical cystectomy. The other reality is not everyone is going to consent to surgery. And so refusal of surgical treatments is something that happens, not frequently, but something we have to contend with. I think for many patients, though, they'd rather avoid having a major surgery and the associated risks and complications and preserve their bladder. There are some patients in particular who are likely to be better candidates to have longer and better outcomes after bladder preservation strategies. And those patients who have a smaller volume of cancer or smaller tumor volume, those patients that don't have swelling on their ureters, those patients, if they have a pouch or diverticulum on the bladder with tumor confined to that area, may be candidates for a partial cystectomy or a smaller type of operation. And then, of course, patients who are able to tolerate systemic therapies or chemotherapy that is normally paired with other treatments to preserve the bladder. Next slide. So what is bladder preservation really? I think historically we thought about bladder preservation in the context of radiation treatment. And you already heard that Dr. McKiernan was part of a wonderful webinar sponsored by Beacon just about a week ago. And I will refer you back to that because there was a lot of very good and detailed information regarding radiation therapy as an alternative to radical surgery. The truth is that there are newer drugs being developed now. There are chemotherapies that are actually even more effective than they were just because of the way that they're being delivered now. And we're thinking that we're entering a new era of bladder preservation in which trying to avoid surgery, obtain a cure for the cancer, and even avoid radiation may be possible. Next slide. If we could go back one. One question that also has come up with this webinar is this discussion that we're having now relevant for aggressive bladder cancers? In other words, some of those that are still within the bladder wall, but working towards the deeper aspects of the wall. And I would say this is exactly the situation that we're talking about now. So these are aggressive bladder cancers that have invaded through the initial lining of the bladder wall and are growing deeply into the bladder wall. Next slide.